Thank you.
Thank you.
Well, thank you, Dr. Parul. I will move on to the next talk, which is on the role of anterior segment OCT in corneal disorders. I think very, very important in today's world. And let's hear what Dr. Chintan has to say on that.
Could you put up the slides, please? These are not nice slides. So moving on to our next topic, ASOCT in corneal disorders. We know that anterior segment OCT is an extremely versatile tool, and the indications for it, which it is being used, are constantly expanding. And while it's impossible to cover all the aspects, I'll try to show some cases where it has been used in, where I've been using it daily. So optical coherence tomography uses low coherence interferometry to enable a non-contact in vivo visualization of the ocular tissues. And the technology has evolved so much that we can image the various structures, range right from the tear film to the conjunctiva, cornea, the muscles, the angle structures, the crystalline lens, and even the axial length of the eye. So we moved on from the time domain OCT, which had a longer wavelength and hence a greater penetration and depth of imaging, but a lower axial resolution. Then next came the spectral domain OCTs, which used a shorter wavelength, for example, the spectralis. Now this had a much better axial resolution of 4 to 7 microns, but a limited scan depth and a width. And now the latest ones which we have combine the advantages of the two, which is a swept source OCT plus a longer wavelength. And so we get a greater scan depth and width, a good axial resolution, which is between the previous two, and also high scan speeds. So these images are very less prone to motion artifacts. An example of two types of OCTs. The one on the left is the spectral domain OCT, which we can see has a shorter depth. So if we want to see the angle structures, we don't see the cornea. If we want to see the cornea, we don't see the angle structures. On the picture on the right, which is showing the cassia, it has a deeper scan depth and also so you can see right from the anterior part of the cornea to the back of the lens, as well as from limbus to limbus and the angle structures in one go. Now the ASOCT can provide us with line scans, corneal pachymetry, epithelial thickness, and the corneal dioptric power. The latter two I've already touched upon in my first talk, so I will be limiting myself to what we see in the line scans in this talk. Before we go on to the abnormal, it's important to recognize the normal. So in a normal OCT, we see the tear film, the interface between the tear film and the epithelium, which is the first hyperreflective boundary. Then we see the epithelium, which is around 40 to 50 microns thick. The next hyperreflective is the Bowman's membrane. Then we see the stroma, and last the Descemet membrane and the endothelial complex. So coming on to each of these indications where we used, OCT is most useful in ocular surface lesions, where it provides an optical biopsy. For example, this is a lesion. We are seeing it on the conjunctiva and the cornea, taking up stain with rose bengal. And what do we see on the OCT? So there's a thickened and hyperreflective epithelial layer with an abrupt transition shown from the red arrow from the normal to the abnormal epithelium. And the plane between the lesion and the underlying tissue can usually be identified. And this is the classic picture which has been described for an ocular surface squamous neoplasia, which we also know from histopathology is an epithelial tumor. The only disadvantage of ASOCT here is that it cannot differentiate between invasive from non-invasive disease, and for that, histopathology is still required. Apart from aiding in the diagnosis, ASOCT can also be useful in monitoring resolution of OSSN. For example, in this patient, we initially gave 3 cycles of mitomycin C, a very good response, but some hyperreflectivity and abnormal thickness of the epithelium still persisted. And so at this point, we gave another 2 months of topical interferon, by which time the epithelium returned to normal. Another case, at the top of the panel, you see the ocular surface squamous neoplasia, but it completely resolved after 3 cycles of mitomycin C. The normal translucency of the epithelium returned on ASOCT, and no further treatment was required. Sometimes it can also guide the differential diagnosis of ocular surface tumors. So we have 2 male patients in their early 40s, and they have pigmented lesions close to limbus in both cases. 3 diagnoses come to our mind. One is a pigmented ocular surface squamous neoplasia. You have a melanoma, and you could have nevi, which are benign, the former 2 being malignant. I will reveal the diagnosis first. The top picture on histopathology was a melanoma, and the bottom was a pigmented OSSN. But while actually preparing for these talks, I saw how the ASOCT differed in these. So a melanoma we know is a subepithelial lesion, and if we trace the red dotted lines, we see that the epithelium is going over the lesion and the Bowman's layer is below that. So the lesion seems to be arising from below the epithelium and then pushing the epithelium up. On the other hand, in the lesion which was actually a pigmented OSSN, we can see that the lesion is sitting right on top of the epithelium and the Bowman's layer and the subepithelial tissue is below and running parallel to that. So it can give us a clue about what it is, though for both melanomas and lymphomas, lymphomas have been shown to have a dark hyporeflective subepithelial lesion. And for both melanomas and lymphomas, the ASOCT images do not always help obtain a definitive diagnosis as they often do for OSSN. But they can guide the differential, and a histopathological analysis is required for melanomas or lymphomas. The second most important indication of ASOCT is surgical planning of corneal pathologies based on their depth in the corneal stroma. For example, this is an 11-year-old boy with bilateral granular dystrophy, not a difficult diagnosis at all. But once we are planning a lamellar keratoplasty, we see on the OCT that majority of the deposits were within the anterior 200 microns. So we went ahead and did an ALTK using a 250 micron head. And this is the first post-operative day where practically there are no deposits seen. It also helps you in the follow-up of these patients. So this patient had a little bit of difficulty in healing problems, epithelial healing problems superiorly, and a whitish kind of a lesion appeared in between the interface. We were not very sure what it is. Looked like an epithelial ingrowth, and your ASOCT confirms the diagnosis of sequestered cells between the two lamellae. Now, if this was left untreated, it could grow on further and encroach the visual axis. So we went ahead and did a YAG cap for this, and it resolved. In case of advanced keratoconus and scarring, again, ASOCT has a lot of advantage. One, it can tell you about the pachymetry at the thinnest point of the cornea, so you can decide your depth of demarcation where you want to dissect. Secondly, you see whether the scar involves the Descemet's membrane or not, because if it involves the Descemet's membrane, then a big bubble DALC is perhaps contraindicated. You can have a rupture. So if you see no scarring of the Descemet membrane in any section, a deep anterior lamellar keratoplasty can be safely done. And one could also post-operatively evaluate the interface as to see how much of the stroma you've left behind in case one has done a manual dissection. This was a 23-year-old male. He had gotten PRK done somewhere, and he came after 3 months with complaints of decreased vision. Clinically, he appeared to have a haze. Now, haze in the early phases of PRK is treated with steroids, but you want to know whether this lesion will be responsive to steroids or not. And if you see in the bottom picture, this is a thickening of the Bowman's layer. There is fibrosis and cellularity. This is not a lesion which is going to respond to topical steroids, although a trial was given initially. There was no response, and so this patient has been advised a PTK. One could evaluate the depth of the intracorneal ring segments, the picture at the bottom showing you the ICRS abutting the endothelium, and if it goes further, then it perhaps would be an indication for removal. Another place where it has helped guide our clinical practice is evaluating the demarcation line after C3R. So the appearance of the demarcation line, which is seen as a hyperreflective line, is often taken as a surrogate measure for the effectiveness of cross-linking. And in most cases of epi-off C3R with the Dresden protocol, the demarcation line has been shown to be close to 300 microns at 60 to 70% depth. But recently we started using the riboflavin with the HPMC, which causes greater penetration of riboflavin, and we noticed that a shorter soakage time, the demarcation line with the HPMC were much deeper. They were pre-descemetic. And this lends support to previous literature also, which shows that with HPMC you need to have much shorter soakage times, 10 to 15 minutes as compared to the 30 minutes that you do with a dextran riboflavin. In LASIK, ASOCT is very useful. It helps in identifying the presence of a flap, where sometimes you need to certify fitness for jobs. You can plan retreatments based on the flap and the residual stromal bed thickness. And another interesting case of diagnosis of an interface fluid syndrome, which is also known as PISC. So a young male complained of diminution of vision after 1 month after LASIK, and very high IOPs were recorded. And on slit lamp examination, there was a ground glass haze of the cornea. Once we did the OCT, one could see a clear 50 to 60 micron fluid-filled pocket between the flap and the underlying stromal bed. So this helped to confirm our clinical impression. And so we stopped the steroids and controlled the IOP, and one can see that it has come back to close apposition between that. The other common indication, it's used ASOCT very commonly for a Descemet's membrane detachment. You have a post-operative corneal edema. Sometimes you're not able to make out. If you see a hyperreflective undulating membrane, you know that you have a Descemet membrane detachment which will respond to your air or C3F8. But if you see a taut linear signal, this is a taut DMD which will not respond to air injection, and this will need a descemetectomy followed by a tamponade. Endothelial keratoplasties is a full topic in itself, where it is used intraoperatively to see the orientation of the scroll, postoperatively to see your graft attachments and centration, and also to follow up. For example, in this patient, the graft thinned subsequently, and one could make out that the patient will do well. It has been used various times in cases of infections, specifically in microsporidial keratoconjunctivitis, where it has been shown to have slightly raised hyperreflective dots, vis-a-vis adenoviral conjunctivitis, where it is subepithelial. And last but not the least, this is a case I really like. It's a useful teaching tool. This was a schoolboy who presented with a positive sedal even after a primary repair and very low IOP, and we could see how the sedal was really positive. And just, if you go to the ASOCT, it shows you that the posterior lip is gaping. If some resident sees this, I think they're never likely to forget the importance of good corneal suturing. Once the cornea suturing was done, the sedal became negative and the IOP recovered. So to end, there are a lot of indications. There are many more for which ASOCT can be done. And I think it acts as a third eye for our clinical diagnosis to what we see on the slit lamp also. Thank you.
Yeah, thank you, Dr. Chintan, for an excellent talk on anterior segment OCT. As we know, the indications for doing anterior segment OCT are increasing day by day. Now, even the intraoperative of use of anterior segment OCT in keratoplasty and so many other conditions is being highlighted. So I think we can have one or two questions at the end of the talk. I think at the end